Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McCray.
At the end of 2018, Mayo Clinic President and CEO Dr. John Noseworthy is stepping down after 9 years in the leadership role and 28 years at Mayo Clinic. Under Dr. Noseworthy's leadership, Mayo Clinic has expanded and increased its national visibility and is now ranked as the #1 hospital in the country by U.S. News and World Report. Congratulations, Mayo Clinic.
Absolutely. During this his tenure, Dr. Noseworthy led the Mayo Clinic in Jacksonville, Arizona, and Mayo Clinic Health Systems from a group of separate clinics and hospitals to a single integrated organization focused on Mayo's mission. The needs of the patient come first. And we're delighted to have him here with us today. Dr. John Noseworthy, welcome to the program.
Good morning, Tracy. Good morning, Tom.
Dr. Noseworthy, nice to have you. Congratulations on a stellar career.
Thank you very much.
Was it a difficult decision to retire?
No, it wasn't, in a sense, because we have a rotational leadership tradition at Mayo Clinic. It was more about the timing. The trustees asked me to stay on an extra year so we could do the Epic installation and so on. I have a great bench of leaders ready to take the role, and we usually rotate our leaders every 7 to 10 years, something like that. So retiring is that's a different decision, but leaving the CEO role was the timing's good.
Explain that rotational leadership model and how it's different than most places.
So at Mayo Clinic, physician leadership assignments, department chairs, deans, that sort of thing, have moved to be basically a 4-year term with a renewable once. So if you're doing a good job, you'll be in the job about 8 years. In that time, you're supposed to be grooming successors so that the institution will move forward. The CEO role is less defined than that. It's an annual renewable term, basically. You have an annual review. If you're doing good work, you're asked to stay another year. But traditionally, the person's been in that role 6 to 10 years kind of thing. So the timing was about right.
Looking back on it, there had to be some difficult times, some challenging times, some difficult decisions that you had to make. Can you share any of those with us?
Of course. I think the biggest overall decision that the organization needed to make was, did we need to make change or not? Mm-hmm. Mayo has been a fine organization forever. The patient care is outstanding, research, education, and so on. But with the uncertainty of the external environment, the NIH, insurance companies, non-traditional providers getting into the space, we needed to make some changes to be more focused on our outcomes and more focused on our financial performance. And we just did. We needed to have sufficient income at the end of the year to invest in research, to take up the slack where the NIH budget was flat, and to make sure that we were able to fund our pension and fund our growth. And making a change of that magnitude in a highly successful organization like Mayo is difficult because not everyone in the practice or in the institution could see the writing on the wall. Leaders get to see that because that's what we're supposed to do, and we could see that things needed to change. We've made a lot of change. It's been very successful. It's been hard on the staff, but I think we're at the stage where we know our values are strong, our performance is stronger, and that allows us to do good work. And what happened at Mayo basically, Tom, was once people realized where we needed to go and realized that we were going to do this together and always keep our values right in front of us, that we could do this change and that the Mayo brothers would have done it to be strong, then we started to make the change, and it's been good. But that degree of change was tough.
So explain to our listeners, it's hard for many people to understand. This is a nonprofit institution.
Correct.
You just mentioned the fact that we make a profit.
Yep.
Explain how that works.
Absolutely.
And what we do with that profit.
Yeah. So a nonprofit organization still has to have income at the end of the year. That is to say, the revenues have to exceed the expenses. You have to have some money left over at the end of the year to invest in the future. Non-for-profit healthcare organizations use that income to invest in education, research, and the staff. And the fourth component of that we do and many do is invest in the community. And so at the end, you have to make some money at the end of the year to keep the place growing, to keep recruiting good people, and to support the community. And Mayo Clinic has always been very community focused, and we invest heavily in the community so the communities in which we work are strong. So not-for-profits invest in education, research, practice, and the community.
It's the way that the Mayo brothers set it up.
It's the way they set up, and there have never been dividends, there have never been bonuses. That's just the way we are as a not-for-profit.
One of the things that I've heard you talk about during your tenure is that we need to work differently. What exactly do you mean by that?
So we've asked every member, what we said to the staff back in 2009, 2010, Tom, was if we were in the worst recession in 70 years in the United States, people were losing their jobs all over the place, in healthcare and beyond that. And many of our staffs, husbands, wives, uncles, nieces, whatever, were losing their jobs. And so we asked the staff to listen up. We'll make a pledge to you. We will do our very best to make sure that nobody loses their jobs. But for that, we need you to think about working differently. And that is to say, what are the processes of how we care for patients, how we do the administrative work, how we do our research? All of that involves people and processes and technology. Are we doing it in an efficient way? Are we getting the answer quickly, safely, and so on? Or is there some bureaucratic steps in there that don't add value? The other thing we did when we moved from a series of holding companies to a single operating company was the so-called back office side, the business end of Mayo, supply chain, revenue cycle, human resources, legal, billing, all that sort of thing. We had 4 or 5 of all of those as opposed to a consolidated organization. And so we went to a shared service model, which meant all the business was consolidated, and we basically have one legal department for all of the sites. And that meant that those people, there were too many people in the organization. And at Mayo, we're fortunate because we have such a broad range of talented people and jobs to fill that the majority of our folks were able to migrate to a different job at Mayo, not lose their job. But that helped us. The other thing that was very different, Tom, is we had a hiring freeze. And you'll remember that. We basically said we're not going to hire people unless there's a real exceptional need. We're going to take our people that we currently employ and say, who could do this job? There's a job opening over here. Could we, and just by slowing down or almost stopping our hiring for a couple of years, that extra expense basically flattened that line, the growth of the revenue line, of the expense line. The revenue line continued to grow, and the difference between how much we were earning and how much we were spending, that gap grew, and that gave us income to invest in the things we needed to do to get Mayo stronger for the future.
Payroll certainly the biggest expense.
70%.
Right.
70%.
What was the most rewarding part of your job? What will you remember and look back at and say, that was a great part of what I did or what I experienced as CEO?
I think it's exactly the same as I would project you are going to be thinking when you retire, Tom, is you're going to remember what the staff did. And the CEO has a wonderful opportunity. I get to see what everybody's doing all across this magnificent institution, across our 65,000 employees, across all the sites, some of the work we're doing international.
You've been watching?
I've been watching you, Tom. But when you see what our staff do, and a day doesn't go by that I don't hear stories from nurses, from social workers, from researchers, from surgeons, about what they did to meet the needs of those patients. I mean, that just is adrenaline every day. It's just the heroism, the courage, the miracles that happen every day at Mayo Clinic. That just keeps you going.
Can you give us 2 cents on affordable health care? Can it be done?
So thanks. That's a tough question, Tracy. It has to be done. So the answer is yes. We don't know how to do it in the United States, to be honest. And I've said this publicly. I'll say it again. Having a sustainable, affordable, high-quality healthcare system should be a priority of the United States of America. It isn't a priority at the moment. It just isn't. We haven't decided that we want to build a sustainable, affordable, high-quality healthcare system that's informed by research, and so our patients, our citizens, regardless of their socioeconomic status, can afford health care and can get cutting-edge care. We haven't done that. Other countries have put more of an investment in that than we have, but we haven't. And so there are huge gaps, and it's an adult conversation. It's going to take people from all different sectors, not just physicians and nurses, but patients, pharmaceutical companies, insurance companies, life science companies, device companies, and the government, the insurers. We're going to have to look at the education system in the country. How do we educate people about their health? How do we transport people from inner city to the suburbs and so on? All those things weigh in to the health of the country. And we're tied to a 2-year election cycle. So we flip over here with a quick answer here, a quick answer there. That was a bad idea. We have a better idea. This is a tough puzzle. It's worth solving. And I hope the country, and I'm sure it will, eventually says, we've got to get this fixed. And when that's the case, it's going to take some time, and we will get there.
Your successor is Dr. Ferrugia, who's basically exactly like you. I mean, the mold is not going to be broken at all.
Well,
I'm kidding.
We'll see.
I'm kidding. So tell us about Dr. Ferrugia.
Well, Dr. Ferrugia is, he's been at Mayo Clinic for 30 years.
Yes.
He's quite a bit younger than me. He's a gastroenterologist. He's a scientist. He's an entrepreneur and a business person. He's high energy. He's highly intelligent. He's respectful and kind and thoughtful. And he's an innovator. He's a massive innovator. He has a wonderful brain and a wonderful way of solving complex problems. He knows Mayo very well. He's very respectful of our traditions. He has lots of energy. And he wears fancy colored socks. And we've had this raging battle that I wear black socks. But he's going to do a wonderful job. And he knows and loves Mayo. And our staff will rally around him. And it'll be a really fun next set of changes.
Yeah, with those socks, he's with it. You're not anymore.
So you got that right.
The guys with the black socks, it's where it's time for us to go. All right, it's a fabulous institution, and you have certainly contributed to that for 9 wonderful years. Again, congratulations on your career, and appreciate having you on the program.
Now, hold on just a second, because you're both retiring. So I want to know who's the better golfer, because I suspect you guys will be golfing together this spring.
It's not. There's not much to talk about there. Tom is the better golfer. There's no question about it.
I'm not sure about that, but here's what we'll do. We'll have the Noseworthy Shives Challenge. Match play in June, and I'll report back.
Okay, good. I'll look forward to hearing about that.
And it'll probably be a tie if we make it around 18 holes. All right, we've been talking to Dr. John Noseworthy. He is retiring as president and CEO of the Mayo Clinic. Dr. Noseworthy, again, thanks for being with us.
Thank you, Tom. Thanks, Tracy.